So next is the incidental cystic tumor of the pancreas, V5. A 36-year-old woman with vague epigastric symptoms was found on ultrasound scan have a cystic lesion in the body of the pancreas. How would you manage this patient? So nowadays, incidental cystic lesions of pancreas are picked up very frequently because of the too much imaging, ultrasound, CT, and MRI. And most often the cystic lesions pancreas represent a consortium of the condition broadly labeled cystic tumors of pancreas, and these include the serous cystadenomas, mucinous cystic tumors, interductal papillary neoplasm, and solid pseudopapillary tumors. These are generally considered conditions of the borderline malignant potential, and sometimes the cystic degeneration of the adenocarcinoma of the pancreas or neuroendocrine tumors of the pancreas may present a cystic lesion of the pancreas. So, in the presence of these symptoms that are especially suggestive of recent or previous pancreatitis, pseudocystic pancreas can also be a differential diagnosis. The important aspect of the management would be cross-sectional imaging to better define the lesion, and this could take the form of CT pancreas or MRCP. Which of the two proposal cross-sectional imaging would you prefer and why? So MRCP is preferred than the CT because of the communication with the pancreatic ducts with these lesions is not good on the CT. And for the cystic tumor of the pancreas, which is the main concern here, there is a well-established high-risk feature of possible malignant potential on the imaging that needs to be detected or determined. So these features include the size of the lesion, wall of the lesion, wall enhancement of the lesion, solid and cystic components, intercystic septi, and then the communication of the cyst with the pancreatic duct or obstruction of the pancreatic duct. So these are the 6 features which we look at the CT or MRI. The MRCP shows a 3 centimeter cystic tumor in the body of the pancreas with no enhancement of the wall and no intercystic solid component, the septi. There appears to be a communication with side branch of pancreatic duct. What would you suggest to the patient to consider in the management? So MRCP findings suggest a side branch interductal papillary neoplasm as a possible side branch communication. Apart from the size 3 cm, there are no other high risk features as on MRCP. So side branch interductal papillary neoplasm (IPMN) are usually benign, although malignant potential exists, especially if there are higher features on imaging. A 3 cm lesion is at the borderline cutoff for size, but may still be offered close follow-up to determine the stability of the size or the progression. Alternatively, an endoscopic ultrasound scan can be done to do the FNAC to take some fluid that will be sent for assessment of the amylase CA19-9, CEA, and the mucin. However, cyst in the body of the pancreas can be managed, will entail a transgastric approach and thus traverse the peritoneal cavity with the potential for seeding should the lesion be malignant. If surgery was considered, what would the operation be and what are the considerations? A lesion in the body of the pancreas can be addressed by distal pancreatectomy, and this can be achieved either open or laparoscopically. But lymphatic drainage from pancreatic body and tail lesions drain toward the splenic hilum. As such, if malignancy is highly suspected, then the lymphadenectomy will need to include the clearing the lymph node at the splenic hilum and thus entail a splenectomy. If splenectomy is planned, then patient should have pre-op immunization to reduce the overwhelming post-splenectomy infections for 3 bacteria: H. influenza, pneumococcus, Neisseria meningitidis, Streptococcus pneumoniae, Neisseria meningitidis, and H. influenzae. Thank you.